of the period. And we have to go away from this Haiti-like setting here so you can see these photographs.
Ellen actually chose the photographs, so I looked at them on the way in and just say a few words about each of these images. And I think you'll see why I'm a congenital optimist, even though that medical student in Texas didn't see that. This is the, you can see in the background, I wish I had pictures from 1983. There in the background is the reservoir that flooded these people out of their valley. And Conge was a squatter settlement, as I said, and you can see the houses are mostly shacks. And this is the beginnings of the infrastructure that we built there. And the we here is all Haitians, and that's where Partners in Health was born. There's a school, the church there, which became, it's much larger, but that became a post-op ward after the quake. I don't have those pictures there. But this is, anyway, a dusty, barren hilltop in 1983. I need to find some of those pictures next. And the next slide is just the same place 20 years later. It's very forested. In fact, all of that area, you can see what it used to look like because those other hills haven't been reforested. They should have been, but it's all reforested. It has a huge hospital, schools, women's health clinic, economic development initiatives. And, again, people forget that it was born as a squatter settlement. And that gives me a little hope when I'm working in the city in these tented cities. Next slide. And then, Ellen shows this picture, but some of you may have seen it. One of the reasons that we're optimistic is because most of our patients do get better. This is a 26-year-old who I was in another town, and one of my students from Harvard, who's still now a colleague, he wrote me an email, which our email reception's a little bit better in rural Haiti than on Long Island, but he said, well, would you come and see this patient? I said, sure, what's wrong? He said, well, he's got HIV, he's got AIDS and TB, and I said, well, sure, but why do you need me to see him? And I wanted my student to say, because you're the world's greatest infectious disease doctor, but he did not say that. He said, well, we want you to cheer him up. And so I said, what am I, Clowns Without Borders? Now, I said that in New York at NYU, and someone came up to me and said, I'm from Clowns Without Borders, and I'd like you to stop making fun of our work. It's a true story. Anyway, this is why I showed these kind of pictures to people in the White House, and then President Clinton, as I said, became a huge protagonist of this work. This is the same guy after only a few months of treatment. And all these years later, he's still alive. He's a nut. We did not have the medications for his nuttiness and put into, but he's a great, great guy. And I just saw him in Haiti last month. I ran into him. So talk about scale. One of the most gratifying things of my life as a doctor, Ellen, has been to see these programs taken to scale across the world. There are now 5 million people receiving this care, thanks largely to American support. Next slide. And the model, this is a beautiful picture taken by a woman named Lori Wynn. This is in Rwanda, not Haiti. There's the model. That's why they get better. And some of you will guess that this is a picture of a community health worker visiting a patient. And she's checking on her. Usually we do that. They do that every day. Obviously, doctors, nurses, social workers can't do this. But this is the secret ingredient. Or I was just in Silicon Valley. They kept on saying this special sauce. I'm going to write a book about Silicon Valley and its culture. Next slide. And then this is it looks like an artist's rendering, but it's actually a real photograph of our latest hospital in northern Rwanda. This is now, I know it's 2010 because the way the tree's blooming and the fact that the grass hasn't come in. Ribbon was cut in January. It is linked to health centers, which are in turn linked to community health workers, so it's the whole system. And then I was going back and forth, as Ellen said, between Haiti and Rwanda since the quake. And we thought, well, one of the ways for us to build back better is to acknowledge what's happened in Haiti and the dimensions of it. Next slide. And this is the picture that Ellen mentioned. This is the National Palace, which some of you have probably seen. But this was all of the buildings, all of the federal buildings. 28 out of 29 federal buildings were destroyed in the quake. Next slide. This is, of course, we talk about infrastructure. The destruction was, of course, the buildings is one thing, but people lost their limbs, and many lost their lives, but many didn't lose their lives. And then how do you build a disability rights movement? And one of the ways that we've tried to see this happen is to incorporate people like this girl's name is, she's not a girl, this young woman's name is Carmen. Now she is a health outreach worker herself. She focuses on people with disabilities. And if you go onto the Partners in Health website, there's a beautiful video of her, an interview called Walking the Walk, and another young woman who lost, not both legs, but lost one leg, who are now working as community health workers themselves. Next slide. And then, if I may, this is I'll just make this also an appeal. We have taken the leap and said we will build, given that the medical training infrastructure in Port-au-Prince was destroyed, the nursing school, the medical schools, et cetera, were badly damaged. One of the things we did was said instead of building another community hospital in Central Haiti, this is the town where I mentioned I met Ophelia Dahl and many others, my Haitian colleagues in 1983, we decided we'd build a major teaching center in Central Haiti and already started, broke ground last August. We expect this giant hospital, which is the largest project we've ever been involved in, 3 times as big as that beautiful hospital in Rwanda. We hope to finish it in January of next year. So I could say wish us well, but also we're looking for partners. And the partnerships would be, maybe I've talked to some people in this area about light industry there. It's not just, we know that a hospital isn't going to break this cycle of poverty and disease, but we'll create a lot of jobs, a lot of skills. It'll be all Haitian run, but we're going to need to see educational opportunities and business opportunities grow for the people who get better once they receive our care. And I think that may be the last slide. So thank you very much. Oh, there's the hospital. That's what it's going to look like.
Amazing.
Thank you. I feel like applauding myself when I see the pictures. The guy, we lost so many friends, and just looking at those solar panels, I always think about one American named Walt Ratterman who had been helping us in Rwanda and Lesotho and Burundi to solarize our facilities, and he came to Haiti at our invitation and died in the earthquake. So there's a lot of stories like that, which I haven't focused on them, but maybe we could have the lights up.
Yeah, we have about 25 minutes or so for questions. The session's supposed to run till 3:30. 2 people are going to have mics coming down both sides, and I think for the cable purposes, this is all being taped. We need you to use a mic. Any questions? Oh, come on, there must be some questions. Yeah. But use a mic, please. I'm sorry.
This way, and we'll form lines over here. Thank you so much. Hello. I'm Chris Norwood. I run a peer education program in the South Bronx. Thank you for having this program, Ellen, which is very much something I wanted to go to. And when you were talking, so much about the importance of aligning with communities, I started my program for AIDS, Women's AIDS program. We've done diabetes, asthma. As you know, you can prove over and over again, including in the United States, that people without even a high school degree can teach other people to better care for themselves, so they have half the asthma attacks, so their blood sugar goes down. But the basic hostility to this in the United States, in the public health establishment, in the medical industrial complex, is so enormous that you cannot get it to scale.
So I've got to ask you to ask a question.
Oh, so my question is, how do you become a partner if you're in the United States?
Yeah. Well, the hostility that you describe is well known to us. We don't see that so much in rural Africa. Why? Because we're really not competing with anybody. So this term task shifting is kind of a joke, right? When you hear the word task shifting, you assume that the task is taken from one person and given to another. But what I've described is a setting in which no one's helping the destitute sick. So there's actually less competition and less hostility to the introduction of this model there than what we've seen in the United States. That said, we just stuck with it. And some of the work we're doing in Boston has been brought to New York City. Maybe you know about it. I could certainly connect you. Maybe at least have people pushing for the same goals as you. Also, the Navajo Nation, some other cities, Miami. And the reason I'm a little bit optimistic about these partnerships is I think many Americans are understanding that our system is very expensive and that it's very costly to give bad quality medical care to poor people in a rich country. And you have to repeat that several times for it to sink in. It's very expensive to give poor quality medical care for poor people in a rich country. And especially if that rich country has, safety mechanisms, as we do, emergency rooms, et cetera. But that's costly and the outcomes are poor. So I would say, you may be on the edge of a tipping point in primary health care in the United States, in part driven by economic, just the fact that it's too expensive, $6,000, $7,000, $8,000 per capita per year for outcomes that are not acceptable. And it seems to me there's more movement now in the last year around reforming primary health care than there has been in the 25 years or so that I've been involved in medicine. So keep the faith.
Sorry, question here.
I was kind of appalled by your figures about that $1 billion that sort of, 0.03% went to actual municipalities. I was kind of curious about the Clinton and Bush advertisements that were very visible, and I suspect a lot of people gave directly to them. Is that part of those funds, or was that something that went directly to Haitians?
The Clinton Bush Fund is actually a small fund, and it's focused on building enterprise, that particular fund. But I will say that, and the Clinton Foundation has a significant presence in Haiti, and President Clinton and I assume those in the Clinton Bush Fund know these figures and are on our side trying to do, for example, more direct budgetary support for the ministries. And you mentioned municipalities, which is a really important distinction. Now, we need to go out and meet with the mayor of Mirebalais. Here today, I don't know where Abby is sitting, Abby Gardner, who's with me. If you could raise your hand. There you are. So Abby Gardner is among those who helped bring together a group of foundations based in New York or elsewhere to talk about long-term accompaniment of the public sector, at least in public education and public health. And for us, that means not just the ministries, which, as Ellen said, have been destroyed physically, but also the municipalities, the towns. In Rwanda, for example, you really have to coordinate your work with the district authorities. It's required. And the NGOs complain about that, but they do better work. We do better work because we're required to coordinate. And I don't know enough about agriculture or small business development to presume to say that that would also work as a model for, that is, working with the public sector for developing small businesses, but accompaniment is always good. And so whether you're looking, I'll give the example. If we had a light industry in Mirebalais, let's say, believe it or not, I had never been to a rock concert in my life until about 4 years ago. You do believe that, huh? I said that in front of my brother.
Well, that's the way he gets so many books written, so many.
Anyway, there's a band called Arcade Fire, which won an Emmy or Grammy? Grammy. Anyway, they have been big supporters of ours. And, for example, they gave $1 of every concert ticket to Partners in Health in the United States and €1 in their European tour. But they said, we'd like to do all of our album covers and T-shirts and things like that in Haiti. And so did another rock band. Again, I'm embarrassed. I don't have great deep knowledge of rock bands, but I like that they support our work. But then there's not enough electricity, there's not, hookup to water. So those are things that involve the public sector. Obviously, if I keep going back to examples from public health, like cholera, how are you going to fix the cholera problem without strengthening the public sector, the public works department? So I think that even though building businesses is largely a private endeavor, and should be, and agriculture is the same way, there's a lot that we could do to strengthen even the regulatory capacity of Haiti. Because you could say, well, it's like the wild, wild west, and that's good, but it isn't good. You go down there and see, that's why there's so many problems. That's why all those buildings collapsed, because they had no building code and no way of enforcing it.
The answer to your question, though, I think very specifically is that the Clinton-Bush fund is separate. Those are private donations. The numbers Paul was talking about were the pledges from the governments. And as he said, it's been slow being spent because there is an effort made. The good news is that there's being an effort being made to spend it wisely and to make certain that the Haitian government is involved. And clearly it's been a very, very, very difficult process to come back when the very infrastructure of government was so desperately destroyed.
So is the money still there, or has it been spent and disappeared?
The money has largely not even gone to Haiti. So we're tracking the money, the pledges, and where does it sit? And I can give you the website, but if you go to either the Clinton Foundation or the UN Special Envoy for Haiti website, we're tracking it. I was shocked to learn that that's the first time that exercise had been attempted, to actually track and give a platform for transparency on the pledges. And I was, when you it's kind of a name and blame when you say, hey, this country pledged this, or this multilateral pledged that, and it hasn't gotten there. People are, again, I told you my button, umbrage, it will be taken. But it's a good thing, I think, to shine some light on it.
But just to be clear, though, of the money that hasn't been spent, that's still only a very small portion of what was pledged at the UN conference a year ago. And there is the potential, if things get back on track, to, in fact, realize those pledges, not only from the United States, but from all over the world. There was $5 billion pledged. And see, because of this regulatory structure that's now in place through the UN Special Envoy Office, that the money is spent to provide jobs in Haiti, to create contractors in Haiti, and hopefully to stimulate growth in Haiti. But again, those numbers are public dollars. The Clinton-Bush fund is separate, and I don't know if I don't have any. Do you have any numbers on what?
I don't, but I think they have put the numbers up there from there. Where it's a relatively tiny amount compared to these giant pledges.
Again, without being too despairing, I think President Clinton would say to you that even in Banda Aceh in Indonesia, it took several years. And Indonesia is a much stronger country than Haiti in terms of where we started. Haiti had so many problems before the earthquake. So I don't know that we should completely despair at these figures. Also, history's been on fast forward this year. We've had so many other natural disasters and tragedies, and also some big man-made ones. So it's very hard to focus on these issues when you're also dealing with the Middle East and Japan and so forth and so on. Alan, any or other questions? What?
I'll give it to Jack afterwards.
Okay.
Mine just a very simplistic question. They just had an election last week. I know it's probably foolhardy to think that the world's going to change overnight, but is this a positive? How positive? What do you think is going to be the outcome of that change?
Well, I don't want to sound overly cautious because I'm in, and a lot of people like President Clinton is clearly very committed to Haiti and will be involved. And all of us, I think, feel that we'll find a way to work with whomever is in charge. That said, it's a very painful history, the electoral politics in Haiti since 1987. In 86, the dictatorship fell, and there was a big push in 87 to have democratic elections. Those failed and ended in a massacre in which the army was heavily implicated. And then they finally happened again against all odds in 1990. And the Haitians, by and large, keep on electing the same people, and they keep on getting overthrown by military or paramilitary coups, basically. That happened in 1991 and in 2004. And I was quoting actually Amy Walentz's editors here today, and Amy Walentz, is a great writer, and so one assumes that her editor is too. But
I can vouch for that.
She wrote a piece in a newspaper saying, that's the thing about coups, they don't just happen. And so they require a lot of planning and connivance from transnational connivance, you could say. And nobody in Haiti forgets all that. So in the newspaper accounts here in the United States, it's as if history gets wiped away. But unfortunately, participation is dropping, voter participation, every time that the wishes of the Haitian people are ignored through these extra legal mechanisms. Fewer and fewer people participate in the elections. So this last set of elections had very minimal participation, and that's troubling to me because we want the governments who are in power to rebuild and to manage these very significant amounts of capital. They need legitimacy. So it's a lot of us are on triple tenterhooks right now to see what's going to happen, wishing everybody the very best, but worried that there will be a cost to having swept aside democratic process in the past years.
At the connection of capital and finding a way, is there anything you learned from your experience in Cuba about what we can do to make the situation in Haiti better?
Well, one thing I would like to say about the Cubans, and as a physician, as an American physician, is you've given me a chance to say we're extremely grateful to the Cuban people and the Cuban government. They have 1,300 doctors and other health professionals in Haiti right now. And they don't have attention deficit disorder like so many of the other aid people. They've actually been there doing the hard work. And for the first time in 100 years, Haiti would have had no medical school class graduating this year, if not for the 67 who went to Haiti after the last coup and were trained there, all from Haiti, all Haitians, including Cuba, including some kids I knew from rural Haiti. And so thank God they did graduate. I was there. I hope the American embassy liked it. I was their graduation speaker, by the way. Didn't have to say much, but anyway. So the Cubans are doing yeoman's work in providing medical service and in doing medical training. We'd very much like them to be involved with this hospital, and we're assuming that everybody who cares about outcomes, patient outcomes, and training will be supportive of us, including the U.S. government, who would be a natural partner. Now, in terms of investment, I'll make a short answer of the rest of it. Investment in public infrastructure, they're the other end of the spectrum, I would imagine. Haiti has the most privatized education system in all of the Americas. About 85 to 90% is privatized. That's why nobody knows how to read and write. It's all a commodity, whereas Cuba's on the other end of that spectrum, as from what I understand and what I see in the medical education arena. So I don't know, I'm looking forward that we'll have, Haiti's a good place, by the way, for the Cubans and Americans to get along, because Haiti is Cuba's neighbor, and the Americans are putting tons of money into Haiti. So it'd be great to see everybody work together. And I think there are a lot of, I can't speak for American officials, but I think a lot of them would like to see this happen too. I'll just put it this way, Haiti needs their help, the Cubans, and they're there, and they're big. You'll not be shocked to find out what they don't have very much of, the C word, capital. So they have the human capital, but they don't have the money that they need to make this really effective. So we're trying to pull them into our orbit as well, because they're really doing a good job medically. They just need more support.
We have time for one or two more questions. Jack?
Just a question. Extending this beyond just Haiti to the various countries that you've operated, and how much of what I'd call the local medical establishment or other institutions have looked at what you've done, embraced it, gotten involved, or in effect tried to broaden it throughout the various countries?
Really great question. And back to Chris's point, who's sitting near you, the hostility that we've seen in some settings we haven't seen in a lot of, for example, in Siberian prisons, we wouldn't be working there if the government hadn't invited us in. And And I think one of the reasons they did invite us in is more because we were seen to them as doctors, not, you know, human rights critics or whatever, although we are human rights doctors. But we were peddling our expertise, and that worked well with them. We were colleagues, medical colleagues. So the hostility part, it's happened before around, you know, in northern Guatemala, you know, I could give examples. But on the other end of the again, spectrum, where have we had this taken up? I'd say the most encouraging place has been Rwanda. In Rwanda, after our first year of operation, a somewhat skeptical government said, how much does this all cost? And we said, we don't know. Let's get in some consultants from McKinsey.
Boston Consult.
Actually, they did do it for free. And, you know, it was an incredibly cheap amount, you know, tiny figure, under $30 per person per year, for a fairly comprehensive model that went from community to health center to hospital. So then they said, oh, really? That's all? We said, yeah. Because they know, of course, the Rwandans knew about this overhead problem, and, you know, they would openly say, listen, you know, we're grateful for the aid, but half of it goes to overhead, never comes to Rwanda. How about we use some of that overhead to fund the kind of work you're doing? And I went, oh, I hate conflict. No, I didn't really do that. I said, okay, we'll try, and we are trying, but they have embraced this model, our colleagues in the Rwandan government. They started calling it the Rwandan model, because we'd come in saying, hey, look at the Haitian model. It's the Rwandan model. It's been adopted. There were 4 out of 30 districts in Rwanda. There were 4 left with no hospitals at all, and it has been, Partners in Health has worked with the Rwandan government to build those hospitals in 3 of the 4, and it's being widely taken up. They've trained 55,000 health workers. I showed you the hospital. The hospital, that beautiful hospital that I just showed you, the one that's already built, not the one that is being built, that is owned lock, stock, and barrel by the people of Rwanda. It's a public health facility, and that's our MO in Haiti now, too. We only build public infrastructure. So we're a private NGO, Partners in Health, and its sister organizations, building public infrastructure. And that's, by the way, talk about tinkering with the aid system. We should just do that. At least we can do that. You know, make sure that what resources we have, we can bring to bear on some major public works efforts in places like Haiti and Rwanda.
Okay, one last question. I'm sorry, I think that's all we have time for. And I know Ruth has some closing remarks she wants to make.
I'm John Oppenheimer, internist in Sag Harbor. It's a neighboring community. And 30 years of practicing with insurance companies, private insurance companies, and realizing how more and more dominant they are in our system. Medicare is a great program, but even that's trying to be gutted right now. Is there any way that Partners in Health can interact with the private insurance companies, and is there anything that the private insurance companies would see it in your model to make it successful, to be spread, you know, more widely?
Thanks, John. That's a great question. I think the short answer is yes. There is a way, and if they're smart, which I'm told they are, then they will notice that, back to what Chris said, that if the highest quality of care for chronic disease is community health workers, they should notice also that that's lower cost and prevents bad things like emergency room visits. If I were running even if I weren't an insurance company, but running a major hospital in New York or Boston, I would, just for economic reasons at the very least, start finding ways to reimburse community health workers for services rendered. First of all, that will also help in areas with high unemployment. You can retrain people with, let's just say you say, okay, you need a community college associate degree, or you could say, you know, again, there are plenty of people with high school diplomas who might not have college education, but could be trained to do this, and then could use that as a springboard towards more higher education. So I think no matter how you slice it, the community health worker model is urgently needed to improve the quality of care, to decrease costs, the secondary goal, and you know, it can have a lot of other echoes, positive echoes, you know, positive synergies, whatever you'd like to call them, in terms of addressing some of the high levels of unemployment we read about. Yeah, I heard unemployment something like 15% in California. I don't know if that's still the case, and there are pockets of the United States where it's significantly higher, as you all know. I think, again, this is a very constructive, positive way for the insurers to get a good deal, but most of all for patients and communities to have better health outcomes.
Well, on that note, I think we have to bring this to a conclusion, but before we let you go, I know that Ruth Appelhoff, the director of Guildhall, wanted to say a few words. Thank you, Paul.
Thank you.
Fantastic.
Thank you all.
I want to thank Paul Farmer for wonderful insights into healthcare and invite him to come to the United States and work on our system too. And of course, Ellen Chesler, who has been so amazingly instrumental in organizing this entire day for us. Ellen, we couldn't do it without you. Thank you. Also, if I may, I'd like to thank our Chairman of the Board of Trustees, Mickey Straus, who was the partner in crime with Ellen doing this wonderful effort for us. I hope you'll come back July 15th through the 17th. We have a lot more panels and talks waiting to interest you and inform you and inspire you. And I thank you all, the fellows and our sponsors, Dayton, Ritz, Osborne, and Chubb. Thank you very much. The Tarr family, as I said, the Hamptons Institute fellows, Andy Rich, and the whole Roosevelt Institute gang. We really, really have loved this. And thank you. Be sure and pick up a book in the lobby on your way out. Thanks so much for coming.